afternoon to one and all. A warm welcome to the 31st Annual Conference of Indian Society of Organ Transplantation, ISOT 2021 KOCHI, a program organized by a team of transplant professionals. The Indian Society of Organ Transplantation has set its mission to provide national and global leadership in the practice of organ transplantation. An affiliated society of the Transplantation Society, ISOT holds a responsibility to establish guidelines of clinical practice, advance programs of education, and to promote ethical standards for clinical care and scientific investigation. With over 1,400 members across India composed of kidney, liver, and other organ transplant professionals, ISOT establishes an active interest in basic science, clinical research, and improving clinical practice in the field of transplantation. Before we begin, may I take this opportunity to welcome the President of Indian Society of Organ Transplantation, Dr. Jayaprakash Ojha, Secretary Dr. Vivek Balakrishna Kurte, Treasurer Dr. Narayan Prasad, and the other executive members. ISOT 2021 KOCHI takes immense pleasure in inviting you to the 31st Annual Conference of Indian Society of Organ Transplantation, held at Hotel Grand Hyatt in Kochi, Kerala, India, a venue of international standards. The coming 4 days is bound to be surplus with an academic fiesta, and the organizing committee has left no stones unturned and promises that you return abounding with new knowledge and the recent advances in organ transplantation. We are fortunate to have renowned experts across the globe as speakers with a wide range of topics. This conference also gives you an opportunity to interact with the experts in the field. Introducing to you the organizing committee of ISOT 2021, Dr. Ebi Abraham, the organizing chairman, the organizing secretary, Dr. Rajesh R. Nair, and Dr. Maman and John, the treasurer. Without further delay, let's move on to the scientific sessions of the 31st Annual Conference of Indian Society of Organ Transplantation, ISOT 2021. Please note, specific timings have been allotted for each of the sessions. You have a total of 10 minutes, 7 minutes for the talk, and 3 minutes for discussion. Kindly request the speakers to stick to the timings and humbly request the moderators and chairpersons to ensure the same. This is for the smooth conduct of the program, requesting your cooperation for the same. For the first free paper session, may I invite the moderators for this session, Dr. N. Gopalakrishnan, Dr. Sharmila Tukral, and Dr. Mohan Patel. The first free paper of this session is on diabetic kidney disease, post-renal transplant infection profile and graft outcomes, a demi-decade experience from a tertiary care center in South India. May I now invite the speaker, Dr. Asha Thomas V. Over to the moderators for the session, please, sir. I request the moderators for the session to take over. Dr. Maria Paula Gomez.
Yes, hi, I'm here. I'm ready.
Yeah, ma'am. We shall start with your presentation on quality management system applied to organ donation, United Arab Emirates experience.
Okay, thank you very much. May I ask to share my screen because I think that is blocked. Okay, so good morning, everyone. Good afternoon in India. And first, I have to say thank you to the organizing committee for inviting me to be here. It's a pleasure and an honor. So today I would like to talk about the quality management system applied to organ donation, the experience in United Arab Emirates. As all of us know, Emirates is ranked very high in the Human Development Index, has a very good medical infrastructure and availability of all medical experts in all specialties, and organ transplantation is not an exception. The country has a unique situation due to 80.5% of their population is from abroad, with more than 200 nationalities that create a multi-ethnic, multi-faith, and multicultural nation. Transplant program activity historically based on living donation and started from many years ago. Nevertheless, brain death certification law was approved only in July 2017. And from 2017 to date, more than 40 deceased multi-organ donors have been procured. Donation and Transplantation Institute in Barcelona, together with the Emirates National Transplant Committee, we have been cooperating for the establishment of a consolidation of the disease organ donation program in the country. So what we did, we implement in 4 hospitals in Abu Dhabi, the in-hospital organ donation unit. And for this 4 unit, we apply the ISO quality methodology together with ODECU's methodology. We work with all 4 units around 7 spheres about context, leadership, planning, support, operation, evaluation, and improvement. As an example, we define the process mapping, the unit core process, the structural and governance procedures. We identify and define quality objectives and key performance indicators in disease organ donation. All of these activities were agreed with the director of the hospital and together with international speakers. We did a monthly registry that contained all the activity of the hospital organ donation unit and monitor the implementation of all of these indicators and process and procedures together with international experts. Finally, these international experts perform visits to this unit, and at the end of the program, an internal audit was performed, and some of these hospitals achieved the criteria to pass an external quality accreditation. These are the 4 indicators, key performance indicators utilized. There were 1 regarding identification of death by neurological criteria, referral of potential deceased donor, family consent, and conversion rate. And it was set an international target, but also the Department of Health in Emirates decide a specific target for the region. As a result, from the 4 hospitals, 73 possible donors were referred, and 57.6% of the one who died were declared brain dead, which is comparable with international standard. And if we compare with the previous year, the same hospital were referring only 2 brain dead. From these 19 brain dead cases, finally, the conversion rate was, the family consent rate was about 50%. And the main reason why the other donors were not possible to convert was due to medical contraindication, cardiac arrest, and logistic issues with the donor families living abroad of the country. Additionally, as I mentioned to you, one of the units, a 3rd level donor hospital in Abu Dhabi, implement this disease organ donation unit and was qualified and certified for their program in quality in organ donation. And these are the 2 tools used to perform the audit. In one side, we audit and monitor the disease organ donation process, the detection, the referral, the use of brain death protocol, the maintenance of the potential donors, the family information, how the information to the family was provided till the conversion of the donor. And in the other side, it was analyzed, as I mentioned before, the different spheres of the ISO quality system, the context, leadership, planning, support, operation, evaluation, and improvement program. As a conclusion, establishing a self-sufficiency, a sustainable organ donation program is a multifaceted process. The main elements to be considered are supported hospital governance, governmental endorsement, a robust educational program to expand the professional pool, process measurement, international collaboration, and all of them are elements of the quality management system. So thank you very much. I would like to thank all the people. This is my last slide. I would like to thank Dr. Ali, who is the leader and the head of the Disease Donation and Transplant Program in Emirates, and Dr. Hala, who was at the time the intensive care doctor and the head of the organ donation unit at Mafraq Hospital, the hospital who was granted with the quality certification in organ donation. Thank you very much.
Thank you, Dr. Maria. The session is now open for discussion. Any questions from the audience can be entertained. Questions? Thank you, ma'am, for this. Any questions? Well, thank you, ma'am. There are no further questions for this session, for this paper. Now, may I invite Dr. Asha Thomas V for the paper presentation on diabetic kidney disease post-renal transplant infection profile and graft outcomes, a demi-decade experience from a tertiary care center in South India. Dr. Asha Thomas, over to you.
Good evening, everyone. My topic for today's podium presentation is diabetic kidney disease, post-renal transplant, graft outcome and infection profile, a demi-decade experience from a tertiary care center in South India. My guide for the same is Dr. M. Jayakumar and Dr. E. Ramprasad. Before moving on to the study, I would like to give a brief background onto the need of the study in the present day scenario. As you all know, diabetes is one of the leading cause of end-stage renal disease, and diabetic kidney disease develops in around 40% of the patients who are diabetic. So as a diabetic pandemic is on the rise, so are the cases of diabetic kidney disease for which renal transplantation is a therapeutic modality of choice. So as you can see in this picture, diabetes has now become a global emergency with around 642 million patients getting diabetic by the end of 2040. So this is a retrospective cross-sectional study which is aimed at identifying the clinical profile of patients with end-stage renal disease due to diabetic kidney disease who underwent renal transplant at our study center. The second aim is to analyze the spectrum of infectious complications along with their 1-year graft outcome and patient outcome. Methodology of the study: in this retrospective cross-sectional observational study, all the patients with diabetic kidney disease who underwent renal transplant between Jan 2015 to Jan 2020 were included, and their 1-year graft outcome and infectious complications were analyzed from the data collected from the medical records department. Regarding the demographic profile of the study population, there were a total of 192 renal transplants which happened between 2015 and 2020, out of which only 27 patients were diabetic renal transplant recipients. The mean age of the study population was 49 years with male predominance, and the main type of transplant was live-related transplant followed by cadaveric transplant, and the most common donor was a spousal transplant. And the follow-up period of all the patients were 1 year. And regarding the parameters pertaining to infection profile which were analyzed, the most common induction agent used was ATG followed by basiliximab, and all these 27 patients were on triple immunosuppression using tacrolimus, MMF and prednisolone. None of them were on cyclosporin or azathioprine. Out of the 27 patients, 3 patients, that is around 11%, received anti-rejection therapy, and 33% of them had some form of leukopenia at the time of infection. And all these 27 patients received CMV and PCP prophylaxis. None of them received INH prophylaxis. And regarding the infection profile, around 67% patients had documented infections at the end of 1-year follow-up. And the most common infection observed was urinary tract infection, which was seen in 51% of the patients. And the most common infectious agent was Klebsiella pneumoniae, followed by E. coli and Proteus. The second most common infection encountered was wound sepsis. Out of it, 9 out of 27, out of which 6 were surgical site infection and 3 were lymph wound infection. And the most common etiological agent found was Staph aureus, followed by Pseudomonas, beta hemolytic streptococcus, and fungal wound infection in the form of Aspergillus infection. And regarding viral infection, CMV infection was seen, out of which 2 of them had CMV syndrome, and the remaining had CMV disease in the form of CMV gastroenteritis. Varicella zoster was seen in around 7.4% of the patients. To note is that out of 27 patients, 3 of them developed fungal infection. 1 had fungal wound sepsis with Aspergillus. 1 patient had fungal rhinosinusitis caused by Aspergillus. And 1 patient developed graft mucor. And this is a graphical representation of the spectrum of infectious complications seen in diabetic renal transplant recipients. As you can see, the most common infection encountered was urinary tract infection, followed by wound sepsis. This is a timeline of infection. As you can see, less than 1 month, bacterial infection predominated. And more than 1 month, we can see viral infection in the form of CMV, viremia, and herpes zoster infection. And fungal infection in the form of graft mucor and fungal rhinosinusitis was seen most commonly less than 1 month. The second aim of our study was to analyze the graft outcome at the end of 1-year follow-up. It was seen that around 48.1% of the patients, that is 13 out of 27, retained good graft function, whereas 37% patients went into chronic graft dysfunction. 3 patients out of 27 died due to infection, leading on to multi-organ dysfunction and shock. 1 patient suffered graft loss and went on to maintenance hemodialysis. The graft loss was secondary to biopsy-proven acute cellular rejection. So this is a graphical representation showing the various graft outcome at the end of 1 year follow-up. As you can see in this picture, around 48.1% of the patients retain good graft function at the end of 1 year follow-up. And these were the etiologies of chronic graft dysfunction. And regarding the cause of mortality, 3 patients out of 27 died, out of which 2 out of 3 were due to fungal infection, and 1 was due to bacterial infection, which led on to MODS, shock, and DIC. The third aim was to analyze the patient survival. With only 3 deaths, 1 year patient survival was around 89%. And also risk factor analysis with the outcome as well as infection profile was done. And it was found that there was no correlation between the age, sex, induction agent used with the graft outcome as well as the number of infections among the study population. However, as the general norm, among the diabetic renal transplant recipients, live-related transplant had a better graft outcome than deceased donor transplant. So in conclusion, despite being the most common cause of ESRD worldwide as well as in India, only 14% of the renal transplant recipients at our study center had diabetic kidney disease as a cause of end-stage renal disease. And the overall incidence of infection in diabetic renal transplant recipients were around 67%. And regarding the infectious complications, urinary tract infection was the most common infection seen post-transplant, followed by wound sepsis. Thank you.
Thank you, Dr. Asha. It's now open for discussion. Any questions from the audience? The session is now open for discussion. Any questions? It seems there are no questions. Thank you, Dr. Asha, for the talk. Move to the next talk of this session. Dr. Chloe Ballester, are you there? Dr. Chloe?
Here I am.
Yeah, good afternoon, ma'am. Let's start your talk on new technologies applied to master education in the time COVID-19. Over to you.
So thank you very much for giving me the opportunity to present you what we have done in the University of Barcelona together with DTI regarding the master degree, how we have changed our modality in order to be able to continue offering training despite COVID-19. So I am representing my colleagues, professors from the University of Barcelona and
excuse me, ma'am. Ma'am, excuse me, could you put it on slideshow?
So sorry for that. I don't know why is
yes, ma'am, you can continue.
Happening. Okay.
You can continue.
So as I was saying, I represent the colleagues from the University of Barcelona, and then what happened is that the University of Barcelona has been offering since 2004 a master degree in donation and transplantation of organs, tissues, and cells. And since 2011, the program that we had was a blended modular structure. And that means that it included 4 different modules from where the students had to choose 3. One was about organ procurement, the other one organ transplantation, the other one about tissue banking and advanced therapies, and the 4th was about management, quality, innovation, and leadership. In 2020, due to the pandemic restrictions, we had to adapt the program to be fully online. And that means that we had to move from this picture in here with hands-on in simulation to a Zoom live session simulation. And how we did that, and why did we study that? Well, the aim of this abstract was to really analyze the impact of the pandemic on the grades and the satisfaction of our students. So the syllabus remained stable, so we didn't change the contents, but we had to change the modality. Until 2019, there was a face-to-face training that included theoretical classes, simulations, clinical cases, debates, and group exercises. And the internships were, of course, done in different centers in Spain, in Europe, and in the United States. Since 2020, we had to move from these theoretical sessions we moved it into virtual classrooms, and we tried to put all the practical simulations, we replaced them by live sessions. To do that, we used also new online tools as immersive training. You can see that is immersive training using goggles with a mobile phone inside. And we did that for the family approach so that the students had the opportunity to meet with family members and to explain them the situation and to get feedback from them. And that had well, it was really an interesting thing, and we have maintained that. And then to try to adapt these internships that couldn't be done, we also created a virtual reality tour into a simulated tertiary hospital in Spain, in where the participants could interact with the different departments. And thanks to that, they could get an idea about what is called the Spanish model in organ donation and transplantation. A part of that, we gathered a lot of videos so that the students could really somehow understand how the process was going on through videos without having the internship. So the data of the study is organized into different periods. One is from 2011 to 2019, and then the second period in 2020. In these two periods, we studied the grades obtained and the students' satisfaction. As comparative results, we can see that there is a slight difference in the values. So you can see in here the participant grades were in main of the topics was higher. And then regarding the satisfaction, of course, the one that was decline was the internship. But if you look at the other ones, the satisfaction was also higher. So as conclusions, we can say that the inclusion of these new technologies have been absolutely essential to keep offering a high quality training, but also it has facilitated the international educational program, so that the international trainees could be without any problem in there. So I think that the aim and the goal was achieved. And now the point will be to see how to maintain that, how to keep the positive aspects on that, and to keep on going, improving the efficiency of the program. So that's all. Thank you very much. Sorry for this technical problem that I couldn't share the complete screen, and please do not hesitate to contact us if you're interested in knowing more about the master degree that is offered in the University of Barcelona. It is a 9-month course, so you can do it in 1 year or in 2 years, and well, it's basically international, and there is a great interaction among the specialists and the participants. So thank you very much for this opportunity.
Thank you, Dr. Chloe. The session is now open for discussion. Any questions? Thank you. Let's move to the next talk. May I invite Dr. Maria Paul Gomez for the paper presentation on Odisha Organ Donation Innovative Strategies for Southeast Asia. Dr. Maria?
So now I would like to present to you an European project called Odyssey, Organ Donation Innovative Strategies for South Asia. This is a project that had been developed with 4 countries in Southeast Asia, 2 universities from each of the countries, Malaysia, Myanmar, Philippines, and Thailand, and 3 universities and 3 European countries, Spain, Italy, and Croatia. Spain with University of Barcelona and Donation and Transplantation Institute, Italia with University of Bologna, and Croatia with University of Zagreb School of Medicine. And the objective of Odyssey was to develop an innovative and sustainable specialized training program. So that we would like to create is a postgraduate diploma in disease organ donation. And additionally was to set the basis of a network of highly qualified professionals. These professionals, after being trained, they will be able to change policies and practice related organ donation, and finally establish a sustainable and efficient organ donation system in these countries. And at the end of the day, something that all of us we want is to increase the disease organ donation rates and organ transplantation. So the project, this European project financed by or co-funded by the European Union, has different working package. The first one was about the diagnosis study. We divide this group in three subgroups with university personnel, trainers, and trainees. And we assess them according to existing educational programs in organ donation, internet access, and digital literacy, self-assessment in organ donation, self-assessment in non-technical competence, and attitude and perception on organ and tissue donation. The training program itself was developed in two parts. The first part was to train the trainers with an online and face-to-face methodology, and the second part was the postgraduate program. Before COVID, it was considered an online face-to-face, but due to COVID, we have to convert also this face-to-face part to online. They developed informative or awareness event online, and also they implement something that we call on-the-job project, that I will explain you. This is a multi-level online postgraduate program, which means they were evolving from a basic level of information to intermediate and then to advanced at the end of the program. The results, according to the self-assessment survey, show that both trainers and trainees define organ donation as respectful, positive, and reported a positive attitude about organ donation after death. And also we found some small differences between the two groups regarding self-assessment of clinical competences. For example, diagnosis brain death. So in dark blue are the trainers, in light blue is the trainees. You can see here also, for example, in family approach, of course, the trainers, they feel more confidence about the family approach, brain death diagnosis than the future trainees. And regarding self-assessment of non-clinical competencies like problem solving, initiative, teamwork, motivational. Also, there were a slight difference between trainers and trainees. Also, at the end of the trainers, we evaluate the level of knowledge that the students acquire, in this case, the future trainers. We did a pre-survey and a post training test, and then we observed that there were a knowledge increase, about 13.4% of increase in the comparison of the two surveys. If we analyze country by country, all of them increase, but the highest increase was observed in Myanmar with 16.7%, following by Thailand with 14.8%, Malaysia with 12.9%, and finally Philippines with 10.2%. As I mentioned to you, the postgraduate diploma was already implemented during 2020 and the first semester of 2021. We had to convert the face-to-face program to online and live streaming session, and the students also implemented the on-the-job project, which is some small research studies or activities that the students had to implement inside of the hospital. So in that sense, there were at the same time acquiring knowledge, but also implementing that knowledge or applying that new knowledge in their own hospital. As a consequence, and this is from one of the countries, this is from Malaysia, that happened is that not only we were able to increase the level of knowledge of the new students, or the new network of professionals, also it was able to increase and improve the disease organ donation rate. This is a slide from Malaysia that they say that 41 actual disease organ donors and tissue donors registered in 2020, compared with only 28 in 2019. And remember that in 2020, we were in COVID pandemic situation, so they were also closed. The system was closed for some months. So it's remarkable that although they closed and stopped the disease organ donation and transplant system, they were able to do more activity than the year before. And also the highest increase was regarding the consent rate. They were able to improve in 155% the consent rate in their hospitals in Malaysia. As a conclusion, we can say that the innovative approach of Odyssey as a multi-level educational intervention revealed different results between trainers versus trainees on perception, attitude, clinical knowledge versus not clinical competencies. Both groups showed a higher self-assessment score on very good to excellent for trainers, and significant knowledge increase was reported upon completion of the train the trainers. I would like to thank all of these members of Odyssey program from Asia, from Southeast Asia countries, and also I would like to thank my team in Donation and Transplantation Institute, like Elisabetta, Sandra del Cerro, Melania and Patricia, who have been collaborating during these 2 years and a half in the project. So thank you very much, and I'm more than happy to answer any question.
Thank you, Dr. Maria. The session is now open for discussion.
Hi, Dr. Anish.
It's a wonderful study. Thank you for that. Which all centers collaborated with you, just for my understanding? Which all centers collaborated with you?
It was an European project,
Okay.
so it was between universities mainly. It was 8 universities in these 4 countries, 2 per country, and our universities here in Europe, Italy, and Spain, Italy, and Croatia. But the novelty of this program is that we also involve hospital. So all of these new students that were involved in the postgraduate diploma was mandatory for them to be linked actively working in a hospital. So at the end of the day, also their centers or their new knowledge, and they apply this knowledge in their centers.
So you mean to say that both educational institutions and purely clinical oriented hospitals both were involved?
Yeah, but the officially involved were the universities, because this is an Erasmus Plus program sponsored by the European Union, and the officially involved were universities. Only that the methodology that we use allow or take the advantage to also link hospitals.
Thank you, Dr. Maria. There's a lot of effort behind this. Thank you. Yeah.
Thank you.
If there are no further discussions, let's wind up this session. Thank you, Dr. Maria, for your wonderful talk. Let's proceed with your free paper on evaluation of persistent diarrhea in renal transplant recipients, role of norovirus. Over to you, sir.
Good afternoon, everyone. Myself, Dr. Abhishek. I am presenting our study regarding role of norovirus infection in renal transplant recipients presenting with persistent diarrhea. As we all know, diarrhea is most common GI problem in kidney transplant recipients, and numerous cases of post-transplant diarrhea in past has been solely ascribed to immunosuppressive drugs, leading to diagnostic misconceptions and inappropriate treatment. We know that norovirus is one of the most common cause of acute diarrhea, and in recent studies, chronic norovirus infection in post-transplant recipients, specifically solid organ transplant, has emerged as one of the leading infectious causes. Herein, we report the clinical profile and outcomes in patients presenting with persistent diarrhea due to norovirus infection. The objective of our study was to determine the clinical significance of norovirus infection in renal transplant recipients presenting with persistent diarrhea. It was a prospective study. We enrolled the patients presenting to us between December 2019 to November 2020, who were live-related renal transplant patients who presented with persistent diarrhea that was defined as 3 or more than 3 stool frequency per day for 14 or more consecutive days. Patients were evaluated in a stepwise manner to exclude the cause of diarrhea, and they were also subjected to stool norovirus RT-PCR, and all these patients were followed up for the 12 months. The stool samples were collected in the carry-bladder transport media, and it was stored before the running. And the test performed was the TechMin real-time RT-PCR assay that of the fast-track diagnosis. Coming to results, total 39 patients present during the enrollment period, out of which In 29 patients, stool for noro RT-PCR was positive at the time of enrollment. In 10 patients, it was negative. As of today, 17 patients has completed 12 months of follow-up. 9 patients had completed 9 months of follow-up. 3 patients expired before completion of the follow-up. Because our original plan was to include the follow-up sample of all the patients at 3 months, 6 months, 9 months, and 12 months, specifically for the stool norovirus RT-PCR. But because of COVID pandemic, we were able to get at least one follow-up stool sample in 20 patients. There was no stool sample available in 9 of the patients. Telephonic opinion was taken in these 9 patients. Out of 29 patients, 24 were male, 5 were female. Median age of presentation was 47 years, and median duration of presentation as a persistent diarrhea from the time of transplant was 59 months, which ranged from 12 to 143 months. Median duration of diarrhea was 16 days, ranging from 14 to 1 year. 14 days to 1 year. All of the patients had significant weight loss at the time of presentation compared to last visit, and median weight loss being the 6.4 kg. 14 out of 29 patients had renal dysfunction at the time of presentation. In 27 of the patients, stool was negative for any other organism, including opportunistic infections, para, ova, or cyst. In 29 positive patients, all were ABO compatible transplants. More than 3/6 mismatch was there in 12 of the patients. Pre-transplant immunosuppression was received in 2 patients. 11 patients received ATG, 6 were received bacillus, and 4 patients were treated for rejection before the enrollment as a persistent diarrhea. Now coming to the patient population, out of 29 patients at the time of presentation, total 20 patients were receiving triple immunosuppression in the form of prednisolone, mycophenolate mofetil, and tacrolimus. After ruling out other etiologies, mycophenolate mofetil was stopped in 10 of the patients, among which at 1 year, 5 patients has weight gain and they had stable renal function, among which 1 patient has persistent noro RT-PCR positive even at the 9th. In 4 patients, there was no weight gain, out of which 3 were ultimately ended to end-stage renal disease and maintenance hemodialysis. 1 patient who was not on maintenance hemodialysis, who had stable renal function, his stool for noro RT-PCR was positive even at the 12 months. In 1 patient, diarrhea responded at the 6 months after withholding the mycophenolate at 6 months. He had steady weight and stable renal function. His stool RT-PCR was positive even at 6 months and 12 months. Mycophenolate was switched to azathioprine in 3 of the patients, among which 2 had significant weight gain on follow-up. Both of them had stool noro RT-PCR positive even at the 12. 1 patient had no significant weight gain, but his renal function was stable. In 3 patients, MMF was switched to everolimus. All of them had significant weight gain and stable renal function. In 1 of the patients, noro RT-PCR was positive at 6 months, and in 1 of the patients, it was positive even at the 12 months. Though patients were symptomatically better and diarrhea had resolved. 3 patients were treated just symptomatically, among which 1 patient had weight gain and stable renal function, and 1 patient has persistent weight loss, and he turned out to be on maintenance hemodialysis. 7 patients were receiving azathioprine as a part of triple immunosuppression, in which in 3 patients they required stopping azathioprine and tacrolimus was switched to cyclosporine after only their persistent diarrhea result. Here we can see that 1 patient has weight gain and stable renal function, but his noro RT-PCR was positive even at 12 months. 2 patients had persistent weight loss and worsening of the renal function. In both of them, noro RT-PCR was positive beyond the 6 months. In the second patient, it became negative after he was on maintenance hemodialysis and his all immunosuppression except for steroids was withdrawn. 1 patient was treated just symptomatically. She had persistent weight loss and worsening of renal function. Her noro RT-PCR was positive even at the 12 months. And 3 patients were continued under low dose azathioprine. 2 of them had persistent weight loss and worsening of the renal function at 12 months of follow-up. 2 out of 29 patients, they were receiving just prednisolone and tacrolimus as a part of immunosuppression, in which tacrolimus was switched to cyclosporine. Both of them diarrhea responded. 1 of the patient has weight gain and stable renal function, but his stool RT-PCR was positive at 9 months and 12 months. And the second patient had no significant weight gain and his renal function was stable. So here my slide, here we are showing that overall the follow-up of the patient at 1 year. Out of total 29 patients, we have follow-up sample available in the 20 out of 29 patients. And 15 patients has noro RT-PCR positive beyond the 3 months or 6 months. Out of 15 noro RT-PCR positive patients, 7 had persistent weight loss, 6 had weight gain, and 2 patients had steady weight. Whereas 5 patients whose RT-PCR was negative beyond 3 months or 6 months. three of them had persistent weight loss, one had weight gain, and one had steady weight. In terms of weight loss, total 11 patients who were positive for the neuro-RT-PCR at presentation, they had persistent weight loss even at 12 months. And out of these 11, 7 had neuro-RT-PCR detection beyond 6 months positive. In 3 patients, it was negative. And among the patients who had significant weight gain, 30 patients, 6 patients had neuro-RT-PCR positive beyond 6 months of follow-up. When we talk in the terms of renal dysfunction, at 1 year follow-up, total 8 patients had worsening of the renal function, out of which 6 had positive neuro-RT-PCR even at or beyond the 6 months. 1 had negative, and in 1 patient it was not available. Among these 8 patients, 3 patients had baseline renal dysfunction and 1 patient had rejection. Other 4 patients had acute renal dysfunction at the time of presentation, and their renal dysfunction worsened over a follow-up period. In 13 patients, neuro-RT-PCR renal function remained stable or improved, among which 7 had neuro-RT-PCR positive beyond 6 months of duration, and 5 patients were on dialysis. In our study, 1 patient was diagnosed with cytomegalovirus co-infection at the time of presentation, and 1 patient had BKV nephropathy and follow-up. And 2 patients in whom, after detection of immunosuppression, acute rejection changes were seen on the biopsy, and they required restarting of the mycophenolate. So to conclude, norovirus is associated with persistent or chronic diarrhea and is associated with a significant weight loss in the renal transplant recipient. It is associated with prolonged asymptomatic viral shedding in the renal transplant patient. So the take-home message being, we should look for etiologies other than immunosuppressive drug as the sole reason for persistent or chronic diarrhea in the renal transplant recipients. The limitation of our study being it is a small sample size, and due to COVID-19 pandemic, follow-up sample for the stool examination were not obtained in all of the patients, and not all the patients underwent extensive GI evaluation for persistent diarrhea. Thank you.
Thank you, Dr. Abhishek. The session is now open for discussion.
Dr. Kadam, it's a very good study. I congratulate you. I think this is the first Indian study where RT-PCR has been done for norovirus. Congratulations.
Thank you, sir.
My question is that you have rightly pointed out, at least in one patient, you could demonstrate presence of CMV infection.
Yes, sir.
So I would write, it's not a question, it's rather a comment. I would like to reiterate the point that in post-renal transplant scenario, just detection of one bug doesn't mean we have reached the whole, we have solved the problem. Sometimes there can be a kind of presence of multiple infections. What it reflects is that it is a kind of net immunosuppression is more. In those who had a poor renal function and then sustained weight loss and so on, I wonder whether other bugs were searched for with greater detail.
Yes, sir. We want to also point out the same thing, sir. The overall net immunosuppression is what it reflects.
Yeah. For instance, tuberculosis of the GI tract, sometimes, it plays a havoc. We have picked up. So because of the net immunosuppression is more, there can be more than one bug.
Yes, sir. Yes.
Congratulate you on this.
Okay. Thank you, sir.
I think this is the first time RT-PCR for norovirus has been done, and we hardly ever think in terms of such a wide prevalence of norovirus in the post-transplant scenario.
I'm Dr. Paul from Westport High Tech Hospital from Kerala, Thrissur. Let me at the outset congratulate you for doing a pioneering study from our country, because many a time we do come across people after exhausting the investigation, we are not finding the exact cause, and this RT-PCR study by you for this norovirus is really an eye-opener. One question that I want to ask is that, did you have any geographical areas that were where these patients came from, or it was absolutely scattered?
No, sir. Actually, as we work in the Gujarat, our majority of the patients are coming from Gujarat, Madhya Pradesh, Maharashtra, and Rajasthan. And these patients were spread throughout all these states.
So it is not even restricted to one state. It is all scattered. So
yes, sir.
Yeah, the common factor then is the immunosuppression, isn't it?
Yes, sir.
Yeah. So that's a very good study. So I hope we find more ways of treating it, other than stopping the immunosuppression.
Yes.
Good study. Congratulations.
Thank you, sir.
Any further questions for this session? There are no further questions. Thank you, Dr. Abhishek. With that, we have come to the end of the first free paper session. I take this opportunity to thank the speakers and the moderators for this wonderful session.